talking about whether amiodarone improves survival post-cardiac arrest. I'm going to talk about things which I don't do in my department, because I'm telling you, we do still give amiodarone post-cardiac arrest, and we start, as if it's a magic drug. So I thought, because time is muscle, and I want to keep my muscles, is to start with the conclusions. And if you are happy with this, you just will abort the lecture at this stage. The conclusion is that look like amiodarone is dying. And there is no more and more evidence that there will be no more amiodarone in the coming guidelines. And why I'm presenting, look like that quarter of the cardiac arrests are due to ventricular fibrillation or pulseless ventricular tachycardia, and 70% will refibrillate after the first shock. So you have to do something. I mean, the idea of we were telling each other, I have a guy who we gave around 20 shocks, 30 shocks. It's not anymore, actually. And now regarding giving antiarrhythmic drugs, is it beneficial? Is it harmful? Does it do anything? Or we just simply, because it's a cardiac arrest. After all, if you achieve, nobody will come and say you are a hero. But if you don't achieve, rarely you are punished if you keep your time and you treated the victim in timely manner. So is this the situation now? We will delete amiodarone from emergency department post-cardiac arrest and keep it in the cardiology floor, for other uses. Or we will still go for what is going on in the AHA guidelines, that amiodarone is still there. So it's a debate. Nobody knows what's going on. After all, amiodarone is a class 3 antiarrhythmic, and it deals with potassium channels. It's a potassium channel blocker, and we are not here for physiology. But why amiodarone came to the picture? Amiodarone came into the ACLS guidelines because of two major studies. One is the ARREST, and it was in 1999, and the other one is called ALIVE, and it was 2002. After these two major studies, amiodarone came to the picture, and it came to the guidelines, and you can see it was published 1998, where you can see that amiodarone is in the picture. So after these two major studies, and still amiodarone is in the guidelines. The first one, as I told you, is called the ARREST, and it's a double-blind placebo-controlled. So it just compared amiodarone to nothing, to placebo. And the target was admission to the hospital. So it's an outside hospital cardiac arrest, and they want to see whether when you give amiodarone, if somebody arrested outside, he will be alive till he reaches the hospital and admitted. And you can see that after that, so many needed bristers, but you can see that those who receive amiodarone at that time needed more bristers, and equally, they did not need much of antiarrhythmic afterwards. And you can see that also what is happening here, that if you receive amiodarone, your chance of surviving to admission was better. But the thing that you can see that if you receive amiodarone, the trend was not too much toward resuming an independent living. So you just admit the patient, but you, most of the time, discharge a vegetative person. So it is effective therapy of shock refractory ventricular fibrillation, but improving survival remains an important challenge. But this was a study, and rarely we study things which deal with life or death. But this was a study, and that's why they were happy with that. And you can see we gain till discharge. And afterwards, independent living, it makes no difference. The other study, the ARREST study also, it was comparing amiodarone to a very famous drug at that time, and it was in any emergency books, lidocaine. And it seems that also the trend that amiodarone was sort of better than lidocaine. But both also, you can see that what is important was giving amiodarone early. But the thing that amiodarone is not on the vendor machine. it has to come with the EMS. So the whole scenario was reaching the patient early. So it is not only that you give amiodarone or not, but you reach the cardiac arrest early. So you shook him early, you start CPR early. So this was a bias. But after that, you need to give it early. So after all, after these two major studies, amiodarone continued to be in the guidelines. Even in 2015 guidelines, you can see that it's still alive, and it is given for refractory VF or pulses VTAC. But the recommendation is not wow. It is a little bit weak. It's a weak recommendation with moderate quality evidence. And that's why we sometimes, if you don't give amiodarone, you will not be questioned that much. But if you don't shock or you don't do a good CPR, you will be questioned. Then people start to be interested. I don't know why they start to be interested in whether keeping amiodarone or not keeping amiodarone. So 2016 was the year of meta-analysis. And there was two meta-analysis, one by Lena 2016 and one done by San Filippo in 2016. And they studied all whatever data we have about amiodarone post-cardiac arrest. And the first one said that the systemic review demonstrated that while amiodarone significantly increased survival to hospital admission, not to discharge, to hospital admission compared with placebo or other antiarrhythmic, it does not significantly improve favorable neurological outcome. So the question now comes whether this is a cost-effective maneuver. So after that, what was the impact of meta-analysis on clinical practice is that the message to the physician, concentrate on CPR and concentrate in early defibrillation and improve your EMS system rather than talking about amiodarone. And the San Filippo meta-analysis did not differ too much. Amiodarone and lidocaine equally improve survival at hospital admission as compared with placebo, but neither of them improve the long-term outcome. Then came a landmark study, which is called the ALPS trial, and it studied amiodarone, whether amiodarone or lidocaine is better, but they compare it to what? They compare it to placebo. And they said that normally, given if VF continues or recurs after the first defibrillation, this is our practice in any resus. And we know that they put in their mind the arrest and the alive, and a recent one, which was done in Norway, and compared amiodarone to placebo, and also showed that there is no much effect on the long-term prognosis. And they just give the EMS 3 vials. One is amiodarone or lidocaine or placebo, and it's blinded. So we don't know that. The EMS doesn't know what they give to the patients. And why there is a placebo? Because of the Norway study. The Norway study showed that there is no much effect of antiarrhythmic compared to giving nothing. And what is the primary again? Is survival to hospital discharge now. It is not resus successfully and return of spontaneous circulation to hospital admission. It is survival to hospital discharge. And the secondary was that you discharge somebody who is in a good neurological condition. And what they say that survival to hospital admission was good. And this was shown with the previous studies. And you can see that statistically significant. But the thing that there is the Rankin score. Rankin score is a score which assesses how potent you are after a cardiac arrest, how good you are neurologically, that we are sending you to the community to be an active member or just a burden in the health system and in the family. And you can see that look like both the drugs compared to placebo was not that much good. And the thing that it again shows that if the arrest was witnessed or the EMS witnessed the arrests, the prognosis will be better. And I can tell you, when I reviewed all of this, it looked like it will be better, even if you give amiodarone or you don't give amiodarone. And the discussion is that you are treating the patient early, if it is witnessed or the EMS reach. So these data may indicate that both amiodarone and lidocaine therapies may be effective for shock refractory bystander witnessed out of hospital cardiac arrest, but may be useless in unwitnessed. It may be useless in unwitnessed. And as I told you, this is early intervention. And early intervention now, if I tell you go early and do good compression and do a defibrillation, the prognosis will be better. But the idea, again, is reaching there early. So now, look like we are moving from chemical era to power stations, that you do mechanical work, good compression, and you give electricity. If you do that early, you are gaining with or without antiarrhythmic drugs. So it's a matter of time again, like acute coronary syndrome, early intervention, time is muscle, and even in arrest, early intervention is better, regardless whatever you do. So now the results are gloomy. You tell me that lidocaine, amiodarone, other antiarrhythmic drugs, given or not given, you are gaining by just bringing the patient to the ER alive with a spontaneous circulation. But his chance of going home alive is not changing. And even if you send him alive, you may send him with a neurological deficit, and he is a burden on the health system and on the family. But let us look at from this point. If you are gloomy and you want to look to the half empty, you can see, okay, there's no statistical significance by major studies now, whether giving amiodarone or you don't give it. So why we will give amiodarone? Let us concentrate on CPR and early shock. But if you are optimistic, sometimes when we resuscitate a patient and we gain, you have to look at the face of the emergency physicians as if they did a miracle. Yeah. We are very happy sometimes that somebody who we resuscitate for a long time, and the next day we are hearing that he is asking for water. So I know it is maybe the difference is 3% towards amiodarone. This is for those who look at the half full. They said, okay, it is the 3% means what? If you take it numbers, it is a couple thousand additional neurologically intact survivor each year. So why we will prevent these couple of thousands from chance? After the study, in May 2017, there was again a meta-analysis, but this time it includes the ALPS study, and again, they are not optimistic about giving amiodarone post-cardiac arrest. Still, they are not optimistic. So among out-of-hospital cardiac arrest patients with shock refractory ventricular tachycardia or VF, neither amiodarone nor lidocaine increased survival to hospital discharge or good neurological outcome. So again, this party says remove amiodarone. So now, you think that in 2018 or 19 or 20 or maybe next month, a new ACLS guidelines will come. How many of us or view of think that amiodarone will still be in the guidelines? So there are questions, thousands of questions they give to practitioners worldwide. You answer these because when we put the guidelines, we want feedback from everybody. So 2015, amiodarone may be considered for VF or pulses VTAC that is unresponsive to CPR or defibrillation and the vasopressor therapy. As I told you, there was weak evidence. Okay, and outside of controlled trials that are large enough to provide useful answers, amiodarone and lidocaine have no place in the treatment of cardiac arrest. And this is a hint towards the new guidelines. So now, instead of considering the use of amiodarone, we should instead focus on interventions that are known to improve outcome. And good compression, defibrillation when indicated, and should be done early. That means we have to improve our EMS system, and we have to improve that each cardiac arrest should be witnessed. So make sure that nobody walks alone. So do you think that we reach this stage? That Amiodarone was born in 1961, and now 2017, we have to visit him in the graveyard and read Fatiha. So rest in peace. Or you think that still Amiodarone is gasping, asking for help, and asking to save him from the nothing he became. And then we need more research, or we are enough with this data from the meta-analysis and the ALPS trial, and we will just say it's over. We don't know. So till this moment, I am in favor of using Amiodarone in my unit, and so many units worldwide are still using Amiodarone, but let us wait for the ACLS new guidelines and see what the rest of the world says. Thank you very much.